Good morning, my dear students. Today, I am going to discuss one of the most important topic in hepatology, that is how we evaluate a case of liver disease. That means the patient is having jaundice or something related to liver, how to evaluate that particular patient. This is important class because in all other classes regarding the liver diseases you will require this uh, preliminary class, because here we will try to understand how the bilirubin and other investigations which are very commonly used in liver disease are formed, and what is the fate, how to diagnose a liver disease with lot of liver functions, and of course has to be supplemented with the radiology aspect. So today we will try to see how we can evaluate a case of liver disease. If we go by the microscopic anatomy of liver, as we know that it is one of the largest part of the body, almost 1.2 to 1.3 kg is the total weight of this liver, and the functional unit of this liver is a hepatocyte. This is a hexagonal solid, cords of hepatocytes around a central vein. The microscopic anatomy, these are the sinusoids, and these are the hepatic artery, hepatic vein, these are the bile canaliculi, and they make a the whole thing as a liver lobule. As we know that it is an organ which received the blood from dual supply, that is 75% of the liver blood supply is by the portal vein, and the 25% of the liver blood supply is by the hepatic artery. And we also know that almost 25% of the cardiac output is going to liver only. In this way you will know that it is so important that almost 25% of the cardiac output goes to a part of the body which is not more than 2 to 5% of the total body weight of the person. The portal venous pressure is normally 7 to 8 millimeter of mercury. This portal pressure, if it is more than 12 13 millimeter, that is high portal pressure. And the most common cause of high portal pressure is portal hypertension, and the most common cause of portal hypertension in our patient is cirrhosis. The cause of cirrhosis are varied. If we go regarding the functions of liver, we know that it is an important digestive organ also, where there is metabolism of carbohydrate, protein and fats is being done. It is a major reticuloendothelial system also, and major part of the phagocytosis of the senescent RBC, WBC are being done in the liver. It is one of the largest endocrine organ of the body. It has got a major role in removal of drugs and hormones, as We know that all the drugs are excreted from the body either by the renal route or by the hepatic route. So if a drug which is usually excreted in the hepatic route and the hepatic parenchymal disease is there, then the chances of toxicity at that particular dose is very high. So we should also know the ways of excretion of a particular drugs and hormones. Of course, it is a major organ in the clotting of blood. For carbohydrate metabolism, it is the major organ which maintains the normal blood sugar by converting glycogen to glucose and vice versa during the fasting state. We know that liver can manage the fasting state for the whole night, and after night 10 to 12 hours of fasting, liver glycogen stores are getting emptied. So 10 to 12 hours of fasting, liver takes care of sugar level from glycogen to glucose, and in the fed state the glucose is converted to glycogen. It is also a common site for neoglucogenesis, that is converts amino acids fructose, galactose and lactic acid to glucose. It also converts glucose to fatty acid for some metabolism. It is a major site for storage of glycogen, fat soluble vitamins, iron. We know that with active vitamin D is 125 hydroxy vitamin D3. Here the first one is made by liver and the 25 is made by the kidney. So the first part of hydroxylation of vitamin D, that is the active vitamin D, is being done by our liver, and the second final step is being done by the kidney. In protein, this liver removes amino NH2 from amino acids, and which can be then used to form energy, or it may be converted to fats or carbohydrates. The liver also converts the toxic ammonia to less toxic urea. It is a major site for synthesis of almost all plasma proteins with specific functions except the immunoglobulins. As we know that we are not able to take, there are two types of amino acid, essential and non-essential amino acids. The body can make essential amino acids from the non-essential amino acid, that too in the liver cells. In lipids, it is a site for storage of triglycerides. It converts fatty acid to acetyl coenzyme A. It also converts acyl coenzyme A to ketone bodies. It synthesizes lipoprotein for transport of fatty acid, triglyceride and cholesterol to the other part of the body. It is a major site of phagocytosis of old RBC, WBC and bacteria. We also know that it is a major endocrine function. The main one is insulin like growth factor, that is the active growth hormone in the adults, which acts via insulin growth factor 1. It also converts T3 from T4, and we know that T4 is the active hormone for the thyroid actions. It also secretes angiotensin for hypertension. For clotting, liver produces almost all clotting factors except factor 8, which is produced by vascular endothelial cells. It is also a major site for activation of major clotting factors, and the bile salt helps in the absorption of fat soluble vitamin from the gut. If we see the role of liver in digestion, lot of bicarbonates are secreted in the bile, which is used to neutralize the acid in the duodenum, because lot of acid in the stomach, if it comes in the duodenum, it will not be activating the enzymes, and the major pH for activation of enzymes is the alkaline. So this bicarbonate is required in large amount. Liver also synthesizes bile salt from the cholesterol, which are used for absorption of fats. These bile salts act as the detergents which emulsify the fats and makes it easier to get absorbed. Liver also synthesizes bile pigments from the heme, which is from the syncytin RBC. It also excretes plasma cholesterol and lecithin, a type of phospholipids. If in pictorial presentations, this is the hemoglobin which is present in the RBC. When the RBC are aged, the heme is taken out in the reticuloendothelial system, and from here the bilirubin is made. This bilirubin is in the conjugated state in the vascular state with albumin. We know this albumin is a large amino acids, so it will not get excreted from the kidney. This conjugated bilirubin with albumin, this unconjugated bilirubin with albumin comes to the liver. Albumin gets detached and this bilirubin enters the hepatocytes. This enters the hepatocytes, and this bilirubin is conjugated by the enzymes. This conjugated bilirubin is soluble in water, and this conjugated bilirubin is easily excreted in the bile. This conjugated bilirubin is excreted in the bile's duct, from where it reaches the gallbladder, and with due course of time this goes in the large intestine, and the bacterial flora present in the large intestine degrades the bilirubin to urobilinogens and stercobilinogen. As we know that this bilirubin which is conjugated enters the gallbladder, and from gallbladder to the intestine. If the person is suffering from obstructive jaundice, this is obstructive jaundice, here the bile cannot enter the intestine, and we will not be having the urobilinogens in the bile in obstructive jaundice. Some part of this urobilinogen is absorbed in the vascular component, and this enters the kidney and is excreted in the urine as urobilinogens. So in obstructive jaundice, we will have difference in the excretion of bilirubin in the urine and in the feces, and by which we can know about the cause of the disease also. Some part of this bile is circulated in the enterohepatic circulation, that is, the total bile acid pool is of 4 grams. This is excreted and comes in the small intestine, colon. From here it is absorbed and goes back to the gallbladder. This is known as enterohepatic circulation of bile salts, and almost 500 milligrams of bile is excreted per day in the feces, and similar amount of 500 milligram is synthesized from the cholesterol in the liver to keep this bile acid pool constant of 4 gram. A little about the hepatocellular bilirubin transport. As we have discussed, this unconjugated bilirubin from the reticuloendothelial system is taken in the blood with the albumin. As we know, this is a large amino acids, cannot get inside the small micro vessels like in the glomerulus and in the sinusoids of liver. So in the sinusoids of liver, this albumin, the bond between albumin and unconjugated bilirubin is broken. This unconjugated bilirubin enters the hepatocytes by active and passive diffusions. In the hepatocyte, it is conjugated with enzymes, and after conjugation this bilirubin is actively secreted into the hepatic canaliculi system. Normally we will see there are a lot of diseases which are known to us, which are because of altered level of UGT enzymes, and these are usually autosomal recessive characters, and if this enzyme is decreased in quantity, the conjugation of bilirubin will be affected and we will have lot of disease which we will see later in this class. This conjugated bilirubin is actively transported across the canalicular membrane into the bile duct. If we see the normal liver functions, the function of the liver can be divided broadly into the storage, degradation, metabolism and synthetic part. Storage is for major for glucose, vitamins, copper, iron. Degradation of insulin, bilirubin, ammonia and lot of drugs. It has got active role in metabolism of carbohydrate, that is gluconeogenesis, glycogenolysis. You must be familiar with these all the three different entities, that is the formation of amino acids from glucose, glycogen from glucose, and glucose from glycogen. Similarly, it has got a major functions in lipid metabolism, that is cholesterol synthesis and lipogenesis. Liver is a major part for the synthesis of albumin. Major coagulation factors except factor 8, C-reactive proteins, lot of carrier proteins like ceruloplasmin, albumin, hepatoglobulins, hormones like insulin growth factors, thrombopoietin, prohormones like angiotensinogens, apolipoproteins, complement proteins, and non-essential amino acids. If we are seeing for liver diseases, what are the manifestation which we should try to look in a particular patients? The pathophysical mechanism of clinical manifestation liver disease can be classified broadly into increasing serum bilirubin due to compromised hepatocyte functions. Second is elevated estrogen levels. Third is because of irregular fibrosis or regenerations. And in the last, if the liver cell is not actively functioning, that is hepatocellular carcinoma. Physical examination in a case of liver disease, what we are supposed to see major, that is icterus, that is yellow colored sclera of the eye. Similarly, we will get enlargement of the liver, and if we try to palpate over that, it will be tender. Lot of diseases of the liver will cause enlargement of the spleen and ascites. Clinically, we will try to see for spider angiomas. We will be very easy to see for skin excoriation in major obstructive jaundice and Palmer arrhythmia in cirrhotic patient. If we classify the liver disease into prehepatic, hepatic, or post-hepatic, that is obstructive, the basic mechanism of raised bilirubin in prehepatic is increased hemolysis, and it is usually unconjugated, and as it is bound to albumin, it is difficult to get filtered in the urine, so we will not be having any bilirubin in the urine, but will have increased urobilinogen, which is by the intestine. The main prototype is hemolytic anemia, as here the liver hepatocyte is normal, so prothrombin time would be normal, and additionally we will see the features of hemolysis on clinical features as well as blood smear investigations. In hepatocellular disease, the basic mechanism of raised bilirubin is deficient uptake, conjugations or excretion by the liver cells. Here we will have the both conjugated and unconjugated bilirubins. As the conjugated bilirubin is there, we will have bilirubin in the urine, and urine urobilinogen would be present. The prototype is acute viral hepatitis. As it is hepatocellular disease, the abnormal vitamin K prothrombin time would be abnormal, but would not get corrected by giving vitamin K because of intrinsic liver disease. Here we will see lot of raised SGOT and SGPT. In obstructive jaundice, the mechanism is deficient excretion due to obstruction of the biliary tract. Here conjugated bilirubin is more, and because of conjugation the bilirubin would be present in the urine, but because the bile duct is obstructed, the bile cannot enter the intestine, and hence the urobilinogen would be absent. The most common is common duct stone or any malignant stricture, as it is vitamin D deficiency because of its absorption. If we give vitamin K, then the prothrombin time would get normal. Here the ALT is usually higher compared to AST. So, dear friends, the basic mechanism of raised bilirubin is hemolysis, and it is usually conjugated. Bilirubin in hemolysis is rarely more than 5 milligrams. A lot of other investigation like LDH are raised because of increased turnover of red blood cells. Similarly, in post-hepatic or obstructive, the bile salt in urine are present, and bilirubin is raised many times compared to prehepatic disease. This is the pictorial presentation of urine bilirubinogen which we have discussed right now. This is the liver. The bile salt is secreted from this place, and this bile goes into the intestine. In intestine, the intestinal bacteria convert the bile into urobilinogens, and this is a colorless chemical. It is excreted in the feces, and then in the oxidation it turns into the yellow color. Some part of the urobilinogen is taken from the intestine into the portal circulation, and from the portal circulation to the systemic circulation, and comes in the kidney, and in the urine it is excreted as urobilinogens and urobilin in the urine. That means if the patient is having obstructive jaundice, this part would be usually not seen. Achloria, that is the absence of bile pigment from the urine. Urobilin or urochrome is the chemical primarily responsible for yellow color of the urine. Urobilinogen is of course colorless. In hemolytic anemia, urine is achloric but has high urobilin and urobilinogens. On exposure to air, this urobilinogens is converted into urobilin. This is the classical phases of a hemolytic anemia, that is thalassemia. Here, this is the prototype of pre-hepatic raised bilirubins, and this is the microcytes and target cell in thalassaemic patients. Similarly, the obstructive jaundice reduces bilirubin excretion, which is then excreted directly from the bloodstream into the urine, giving a dark color urine but with paradoxically low urobilin concentration and usually with corresponding pale feces. This is the sclera in obstructive jaundice. Normally, the bilirubin is very high in obstructive jaundice, and the color of sclera is orange. O for obstructive jaundice, O for orange. Like the color of sclera in hemolysis is yellowish tinge, but in obstructive jaundice it is almost orange. This is so it is a major MCQ where you should know the color in obstructive jaundice. In chronic liver diseases, we will have dupuytren's contracture, that is especially the tendons on the lateral part of the hands are contracted, and they are very characteristic of alcoholic cirrhosis. Similarly, Palmer arrhythmia is also very common in alcoholic cirrhosis. There is a lot of fat malabsorption in liver disease, and this is xanthelasma over the eye, and this is increase bruising because of vitamin K deficiency. This is case Fisher ring in Wilson disease. What is it? Wilson disease? That is also known as hepatolenticular degeneration. That means the patient would have the disease from the liver and lenticular, that is in the extrapyramidal tract. The patient will have degeneration in the liver as well as extrapyramidal structure, that is hepatolenticular degeneration. What is the consequence of bile salt retention in the blood? This bile salt retention will cause fat malabsorptions. It will also cause steatorrhea, that is pale stool which is difficult to flush, bleeding because of decreased vitamin K, and itching. This is a spider angiomas over the nose in chronic liver disease. If we see the spider angioma, it is a permanently enlarged and dilated capillaries visible on the surface of skin, are usually caused by vascular dilatations, are mainly present on upper part of the body, especially face, neck, chest, and upper abdomen. These are the liver palms or palmar erythema in case of chronic liver disease. These are the white nails of chronic therapy of liver disease. So, the signs of advanced liver disease would include muscle wasting, ascites, edema, dilated abdominal veins. Typical smell in liver disease, that is also known as hepatic fetor, astraxis, confusions, stupor, and coma. There are all signs of hepatic encephalopathy. In a male patient with cirrhosis, that too alcohol related, we will also be able to know the signs of hyperestrogenemia, that is gynecomastia, testicular atrophy, and loss of male pattern of hair distribution is also very striking. So, in liver disease, liver is not able to degrade the estrogens, and this high level of estrogen will cause spider angioma, palmar erythema, gynecomastia, loss of male hair pattern, and hypogonadism. In the later stage, when the liver disease is advanced, because of fibrosis, irregular regeneration, we will have nodular livers, and the disease because of nodular liver, that is usually cirrhotic disease, and in the later course of time it may turn to hepatocellular carcinoma also. In nodular liver of cirrhosis, which is advanced stage from where it is difficult for the particular person to revert back, and the patient of cirrhosis will develop portal hypertension. But we have discussed earlier that the normal portal pressure is 7 to 11 millimeter. If it is more than 12 millimeter, that is raised portal pressure. This raised portal pressure will cause enlargement of spleen because of back pressure. This back pressure will also cause caput medusa, that is the opening of portosystemic end arteries. We will have also ascites and bleeding varices because of opening of portosystemic blood vessels, which are normally not raised because normally the systemic pressure is high, so these varices are non opening. Thrombocytopenia can also be there in liver disease, that may manifest as pechichi, purpura or frank bleeding. The thrombocytopenia may be because of enlarged spleen or loss of thrombopoietin production by the liver. Similarly, the cause of bleeding in liver disease may be because of thrombocytopenia, ruptured varices or decreased clotting factors, because the liver hepatocytes damage will decrease the formation of coagulation factors, and the malabsorption of fat soluble vitamin will leads to decrease function of vitamin K dependent coagulation factors. Hypoalbuminemia may be seen if the liver disease is of long duration. Similarly, Terry's nail or leukomycia can also be seen in chronic liver disease. There are two types of hepatopulmonary syndromes or portopulmonary hypertension. Here, because of hypoxia, we can have clubbing, we can have dyspnea and arterial deoxygenation, which is greater in the upright position compared to recumbent position, which is different from the dyspnea in recumbent position of cardiac disease. As the liver is not acting properly, ammonia is usually detoxified in the liver to less toxic urea, but because the hepatocyte is not functioning, this ammonia is not metabolized. It disrupts the neurotransmission by alternating in the GABA pathway in the brain, and this is a probable cause of astraxis confusions in hepatic encephalopathy. Similarly, the cause of fetal hepatitis or the typical smell in the liver disease is the volatile dimethyl sulfide due to portosystemic shunting. We can also have spontaneous bacterial peritonitis and hepatorenal syndrome in a advanced case of liver disease. A little bit about hepatic encephalopathy. An encephalopathy where the primary cause of the disease is liver is known as hepatic encephalopathy. The first sign of hepatic encephalopathy can be subtle, that is very difficult to know, and it may be non-specific. So we should have a high index of suspicion regarding the hepatic encephalopathy. The initial presentation may be changes in the sleep pattern. That means the patient is not sleeping in the night, or he is more sleeping in the morning times, and that is not his particular sleep patterns compared to initial times. There is change in the personality of the person. He is more irritable and there is sluggishness of the mental acuteness. Later on, the patient will have confusions, he would be disoriented, and in the later part, it may come to stupor and coma. This is the asterixis or the hepatic flap, which we should try to elicit in a patients of hepatic encephalopathy, as we know that this requires some amount of uh, consciousness. That means this asterixis would not be present in grade 3 and 4 of hepatic encephalopathy. How to diagnose hepatic encephalopathy in the initial stage? That is by trail making test. Here the test consists of a series of 25 number circles that the patient is asked to connect as rapidly as possible using a pencil. Normal person would connect the dot in less than 20 seconds, and it takes considerably longer in the patients of hepatic encephalopathy. This is the classical trail test. This is the random numbers which are there in the page, and the person is supposed to connect 1, 2, 3, 4, 5. All should be connected in less than 20 seconds. But in a patients of altered disoriented mental function, it would be difficult to do in the required time durations. So if we go for the pattern of liver disease, it is usually divided into three, that is primary hepatocellular, that is viral hepatitis or alcoholic liver disease. In cholestatic, that is obstructive, that is gallstone, malignant obstruction or primary biliary cholangitis, and in a mixed variety, cholestatic forms of viral disease and many drug induced liver disease are included. And as we have discussed earlier, the symptoms of liver disease are same: jaundice, fatigue, itching, right upper quadrant pain, nausea, decreased appetite, abdominal distension, and intestinal bleeding. How to evaluate a patient of liver disease? We have to establish the category of disease, whether it is hepatocellular, cholestatic, or mixed. Then we have to know the etiology of the particular disease. Then we have to grade the severity, and in the severity we have to stage the disease accordingly for the treatment purpose. And in all liver disease, the jaundice is the hallmarks of liver symptoms, and it is usually not detected when it is less than 2.5 milligram percent. So in nutshell, the evaluation of liver disease is divided into four parts: the test based on detoxification and excretory functions, that is bilirubin, serum and urine, and blood ammonia. Second is test based on enzymes that reflects damage to hepatocyte, that is SGOT and SGPT. Test based on enzyme that reflects cholestasis, that is alkaline phosphatase and gamma GT. Measures that biosynthetic functions of liver, that is the serum albumin, globulin, and coagulation factors. First, the test based on detoxification and excretory functions is the bilirubin. We know how the bilirubin is formed. It is formed by the breakdown of heme in the RBCs. There are two types of bilirubin fractions in the blood. One is conjugated, that is water soluble and then can be excreted in the kidney, and the second is unconjugated, which is indirect fraction, which is insoluble in water and is bound to albumin in the blood. Normal bilirubin is 1 to 1.5 milligram percent, and out of this the direct is less than 15% of total bilirubin. That means by default, elevation of unconjugated bilirubin is rarely due to liver disease. It is usually because of hemolysis somewhere else, and conjugated hyperbilirubinemia is usually because of liver disease or biliary tract disease. Urine bilirubin, unconjugated bilirubin always bind to albumin in the serum and is not filtered in the kidney. Therefore, any bilirubin found in the urine is of course conjugated. The presence of bilirubin in the urine implies that the presence of liver disease is a must. Ammonia in the blood, it is usually detoxified in the liver and is converted to urea, and in the striated muscle this ammonia is converted to glutamic acid to form glutamine. It is not very specific to say that this ammonia causes hepatic encephalopathy, but of course in all hepatic encephalopathy patients this level of ammonia is raised from the normal level. The second is test based on enzymes that reflects damage to the hepatocytes. One that is SGOT and SGPT. AST is found in liver, cardiac muscles, skeletal muscles, kidney, brain, pancreas, lung, leukocyte and RBC. We know the normal levels of SGOT and SGPT. In liver disease, if it is less than 300 units, it is usually non-specific, but if the SGOT, SGPT are more than 1000, it is usually because of acute viral hepatitis, ischemic liver injury, that may be because of prolonged hypertension or acute heart failure, or because of drug or drug-induced liver injury. SGOT in obstructive jaundice are usually not very raised, and if it is raised, it may be because of acute phase of biliary obstruction, in which we can have SGOT PT of 1000 to 2000 in range, but usually decreases quickly as the liver function tests rapidly evolve into a typical of cholestasis. In cholestasis, we will have alkaline phosphatase and gamma GT. Out of this, gamma GT elevation is less specific for cholestasis. If we see the ultrastructure of liver, the alkaline phosphatase are found near the canacular membrane of the hepatocytes, and the gamma GT are usually found near the canacular level of the hepatocytes. Here the gamma GT level is raised. Serum alkaline phosphatase